Welcome to the first episode of Emergency Medicine Academy podcast. My name is Hassan Abdurrahman, one of the co-founder and instructors.
And my name is Muhammad Fagir. I'm also one of the co-founders and instructors of Emergency Medicine Academy. Welcome.
And today we're going to talk about a very important topic for emergency medicine doctors, and also might include the nursing team and all the medical staff working in the emergency department. And the topic today is communication.
All right. So let's talk about communication skills. Fine. So Hassan, tell me, why do you think communication skills are important for us as emergency medicine practitioners?
I think communication it is very important and play a big role in our management for patients in terms of the treatment plan, involving the patient with the treatment plan, having good rapport between us as a healthcare providers and the patients, and it is quite important. And so we need to have those skills, particularly for us who work in the emergency department. We consider ourselves as a front line, and we are dealing with very challenging situations in emergency department in terms of angry patients, they got significant demands and they got variable concerns, and they need their problem to be fixed during their visit in the emergency department. So it is crucial to have these skills, and the good news that those, or the majority of those skills, are gainable. So with practice, so people can gain these skills.
Exactly. I do agree with you. And by the way, I found in the literature that about 60 to 80% of complaints against healthcare professionals, and the reason behind serious incidents is miscommunication skills. So it's really important to have good communication skills.
That's totally right. That's totally right. And this particularly for junior doctors who just started their career, and so they might have this concept of communication, and they can start to apply all these skills during their daily practice, and also for other doctors and for us as well. So we need to have more experience regarding the communication skills.
All right. So without further ado, let's jump there and discuss more. Is that okay?
Yes.
So can you tell me what's important to you in terms of communication skills when you go and enter the room and meet your patient for the first time?
So the first thing, it is just like I'm entering the room with a bit of smile on my face. I'm just like a bit welcoming and appreciate that the patient is inside the room and came for help. So I'm just going to introduce myself at first, and I'll make sure that they recall my name, and I'm going to state my position in the emergency department, that I'm a physician. I'm going to take care of them. So I will make a clear introduction, and then I'm just going to sit in the chair. And so we're going to talk about the posture of the sitting in the chair, how ideally we should sit in the chair. So this is the initial things. After that, I'm just going to ask them, how can I help them, or why, the reason for them coming to the emergency department today.
Okay, all right. So you said that you are going to sit in the chair. So this brings the important thing of non-verbal communication skills.
Yes.
Because we have verbal communication skills and non-verbal communication skills. So now we are talking about important aspect, which is the non-verbal communication skills. One of them, that you need to be at the same level with your patient. So if, for myself, if there is no chair available, then probably I will sit in the feet in the couch or in the stretcher. If it's all right and if it's appropriate, I will sit near the patient feet, or I might sit down. Actually, so even in the floor, it's better not to be like standing up and the patient is further down and you are looking to your patient from higher up, which might break the communication. So yes.
I totally agree with you. And I think there is one important point we need to talk about that even before us starting. We need to make sure that the patient is just like in the private area, in private cubicle, and we need to close the curtain just to make sure that patient got some privacy. Even though if it is a curtain and might affect the patient psychologically, and they might start to think that they are in private place, so they will be more comfortable sharing all the information with you. And regarding the position, I totally agree 100%. So you need to be at the same level. And I'm strongly also recommend, me myself, I'm doing this frequently. I'm just like sitting in the chair. I'm just leaning my trunk and my upper body just like toward the patient. This is give the sense to the patient that I'm concentrating with them and I'm wholly focused with them. And all the attention is toward them. So like this, they will feel more comfortable that they got the attention of the doctor.
Yeah, I agree with you. And the other thing as well, whenever it's appropriate, I prefer to shake hands with the patient. I think that also strengthens the communication between us. Of course, like some people, some groups of people, they might not accept that. But when it's okay, I think it will take far away our communication skills from the beginning.
Yes, that's right. And I think, but in some cultures, this might be variable things, but I think it is also good things to be done, and it will build a good rapport between you and between the patient as well. And after the patient introducing themselves, I'm tending to call them by their name while we're going through the history, and I'm just gathering history and information from them. I'm just going to talk to them or just like call them by their names. I think this is also gives a bit of good rapport between us and between the patient.
Yeah, usually I ask them, is it okay to call you by your first name? And mostly they will say yes. And also I say, call me Muhammad. So yeah, I agree with you in that. What about having the relatives in the room? I mean, for example, if there is like 4 or 5 relatives with the patient, are you okay that all of them are there, or
it is.
What do you do usually?
I think it is a bit challenging because sometimes the space in the room might be just like not enough room for all of them to be inside. But I'm just politely going to ask that I'm going to take a permission of the patient if they are okay for the relative to stay in the room, or if they prefer 1 or 2 to stay with them, and then other people can wait outside. So in polite, so I will leave that for the patient himself or herself to pick one of them to stay with them in the room.
Okay. Yeah. Agree with you. Fine. So shall we? I would like to highlight this, by the way. So regarding communication skills, it's found that about 55% is about your body language, and then about 38% is about the tone of your voice, and then only 7% is the actual words you are saying. So actually, it depends largely on the non-verbal communication skills, rather than the talk we are giving and the verbal part.
Yes.
Do you agree with that?
Yes, I agree with that. And in terms of the body language, I'm quite focusing on the eye-to-eye contact, particularly at the beginning part of your history taking or conversation with the patient. I think after we made that posture in the chair, now the patient start to talk and tell us about his problem, and at that time, I think it is crucial just like to maintain good eye-to-eye contact with the patient. So will give a relief that you are listening to the patient and you are focusing about the information coming to you from the patient.
Okay, all right. And you've just mentioned that during the patient complaint. So let's talk a little bit about main complaint of the patient. What's your approach? I mean, I could say like a lot of people, they interrupt quite early. So what do you think about this?
Yeah, and before talking about this, usually when we're picking patients and putting our names against them in the screen before inviting the patient to the cubicle, usually they mention a complaint initially, but that complaint, I'm not going to use it when I'm starting my conversation with the patient, because I think sometimes it might be that's not the right diagnosis for the patient, and patient came with another concern. So I will start generally with open question, and I will give them a time to express. And I think this is a valuable point, because I'm going to put my hands into the main problem and the main concern of the patient by letting him just like express his main presenting symptoms. So I will start with open question, and then I will actively listening to them.
Yeah, yeah. So the main complaint, which is written in the triage notes, is not always right. Is that right? Yeah. So sometimes it might be written something, and then you find the patient symptoms are totally different.
Yes.
Yeah. And the other thing is, usually when the patient is telling his main complaint, people interrupt them quite prematurely. So we used to not to give them the time to express all the features, all the symptoms related to their main problem. I think most patients, they will not take like more than 1 minute or less to tell. So there is no need to to interrupt, and that also might break the communication when we interrupt them quite early.
Exactly right. So like this, when you're going to interrupt them at the beginning, I think like this, you're going to break the connection in the patient minds about the information which are going to tell you. And it might be very important information. So you already miss them by doing this interruption. And then when the patient is coming back to tell you the remaining part of the story, he might miss or he might forget a couple of vital information for you as a physician. And then so eventually you miss it because of the interruption.
Yeah.
And I think this is also not part of active listening. So the patient might have a sense that you are not giving me time. And so, as you mentioned, this will break the communication very early stage, which is not the right things to be done. So active listening, it is just like you are listening and you are processing the information, giving them time to express their symptoms. Yeah.
Yeah. So active listening is really important. I think we should spend like 70% of the time during the interview listening, and the 30% we could be asking and exploring more about the patient situation. Do you agree with this, Hassan?
Yes, that's correct. Yeah, I totally agree with that. Yeah.
Okay.
And I want to highlight one point here regarding the chaperone. Sometimes we might need to invite a chaperone. Mostly we're doing this for purpose of examination. But yeah, if we thought that from the beginning we're going to do intimate examination or generally some sort of examination, I think it is also we need to offer the patient about the chaperone, and let's see how they're going to answer about that from the early conversation. I think this is also important point. Yeah.
Yeah, of course. Yeah. So the Royal College of Emergency Medicine, they have clear guidance about chaperone in the emergency department, and it's clearly stated that all patients should be offered a chaperone, regardless if you are a male examining another male or examining female or vice versa. I would offer them all a chaperone when it comes to examination, or if like the history is a bit, sometimes the history itself, as we will discuss later, it might be a bit sensitive. So in these situations, I will offer the chaperone early, even during the history taking.
Right.
And if the examination is just like general examination, or for example, like hand examination, CNS examination, I would offer them a chaperone. And sometimes the patient might say, I don't like to have a chaperone. If you think it's okay and no issue with that, make sure to document that clearly in the notes.
Yes.
But otherwise, if I'm doing like any like cardiovascular, respiratory, abdominal, any probably like genital examination or rectal examination, for example, it's a must to have a chaperone there. So I would say it's like a statement. I'm going to call one of my colleagues from the nursing staff to be here as well. I think that's important medical legal aspect.
Yes.
Yeah.
And the chaperone is going to support your side if anything happen. So because there is witnessed event.
Exactly.
Yeah.
Exactly. And patient relatives, they are not a chaperone, because I saw that happening many times. So patient relatives, they couldn't be a chaperone at all. It should be another healthcare professional. Yeah.
That's correct. Yes. It is just like misconcept that the patient invited one of his relative inside the room, meaning that there is no need for chaperone. So I think, it is, despite though, still you need to offer the patient a chaperone, because the relative is not considered to be a chaperone. Yes.
Okay. What about jargons? Using medical jargons?
We are using this a lot. So unfortunately, I think it is quite important just like to be simple with the patient as much as you can. I think this is also one of the important points of building a rapport between you and between the patient. And sometimes the jargon is coming without us noticing. But if you felt that you already mentioned a bit of jargon while having the conversation with the patient, it is important just like to follow this jargon with a bit of explanation. Yeah.
Exactly. Talking medical jargons, it's like talking to someone in French, and actually they don't know anything about it.
Yeah.
So it kills the communication.
Definitely. And sometimes you feel you can see that in the face of the patient, just like they are just like staring on you, and they have no idea about what you are saying. Yeah. So it is better to avoid it. Yeah.
Okay. All right, Hassan. What about patients' hidden agenda and concerns? How do you explore that?
So in terms of the concern, usually this is after the patient mentioned their story, and I'm starting to process all this information at the end. So at this moment, I should come to the formulation of the management plan of the patient. But before telling them the management plan, I need to explore their concern, the reason for them coming to the hospital today. And I'm sure they are worried about something. So I'm going to ask them clearly, so what is your major concern? What is your biggest fear because of your presentation today? What do you think? And like this, the patient might start to tell me the major concern for them, and I'm going to address the concern first. So in my management plan, the first step in the management plan is just like to address the concern of the patient, and I'm going to assess the concern. Is it matching the same management plan which I came up with after the history taking? Yes or no. If that's the concern is genuine, I'm just going to agree with them. I'm telling them, yes, so your concern is right. So from the history I got from you, we suspected that your problem might be due to this or due to that. And if the concern is not matching, I'm going to also address their concern that from the history I got, it is less likely that your concern is here. Rather, we are talking about something else. So will make the patient a bit happier because they came and all the way driving to the A&E, they're just like having this in their mind that I got this disease and I got this and I got this. So by addressing their concern that this is not the case in here or this is the case, so you already address the concern properly. Yeah.
Exactly. And I would add about this point. Sometimes our patients, because they have concern, they might request inappropriate, for example, investigations or particular treatment. And if our immediate response is saying, no, I don't think this is the right thing to do or to give, then we're not going to go anywhere. But rather than saying no, I would first explore why they are asking for this. Let me give you an example. For example, someone is coming with headache, and actually for me, there is no red flag for that headache, and it's likely benign headache, so I don't think they need a CT scan. But the patient himself start to ask about, can I have a CT scan? So if immediately I said, actually there is no need for CT scan, then there will be an argument. Or even if the patient accepted your advice, they will not feel that they have got the right management. They might go home but come the next day, or they might seek care in a different hospital. But rather, I would prefer to talk to them. Why do you think that you need a CT scan? And they will say, probably I'm concerned about having tumor in my brain. Then my next question will be like, why do you think you might have a tumor in your brain? Probably they will tell me a story that they have a loved one before, friend or family member who initially misdiagnosed, and then he turned to have a brain tumor. So I can start from that point, and I will say, I'm really sorry to hear this, but from your symptoms and from my examination, there is nothing to suggest that you have a tumor in your brain. And usually I would say when they request scans like CT scan, and I don't think they need it, I will also mention that it will be like exposing you for unnecessary high dose of radiation. If we need it, we need it. But in your situation, I don't think we need to go there. And I will give them, good safety netting advice. And if there is no better, they can come back and also to arrange follow-up with their GP rather than just satisfying the patient. There is big difference between patient satisfaction and patient-centered care. Patient satisfaction is associated with adverse events and might cause harm to the patients, rather than patient-centered care, which depends mainly on good communication.
Yeah, exactly right. So I love the question, why, while you are having the conversation with the patient, particularly in the communication part. By asking the question why, you are going to explore too many things. And then you have the opportunity to address each one of them. And will lead to the good sharing plan between us as a physician or as a healthcare provider and between the patient as well. So ask why. I think this will give you more concerning things from the patient side. And then based on that, we can address the concern of the patient, and then we can discuss the management plan with them accurately. So I think it is quite important to ask the question why while you are doing the communication with the with the patient. And I think in the management plan, we need to share all the information and all the management plan, because the plan is between us as a healthcare provider and between the patient. I'm not going to mention to the patient that I will do for you this and this and this and this based on my judgment. Rather, I'm going to share the management plan between me and between him or between her, just like to make sure that we are all in the same page and we are all agreed about the management plan. So like this, the patient will be more happy. And I totally agree the things which you mentioned before regarding if we didn't explore the concern of the patient just like simply might be silent, and he might show that, okay, I agree to your plan, but internally he's extremely unsatisfied about your management plan. And you might think that, oh, all right, so I think things went well with this patient, everything is right. But it is vice versa. The patient is going to leave the cubicle, going home, as you mentioned, and then either go to another hospital or just like coming after ending of your shift to be seen by another physician, which is happening frequently. We are seeing that in the emergency department. Unfortunately, that patient just like keep coming with that because no one addressed their concern right.
Exactly. Yeah, I agree with you. And in terms of management plan, I would like to highlight that most of the time people saying after doing the history and examination, they say let's do some blood tests or let's do some imaging. I would rather prefer to have a chat with the patient first, tell them about my impression and what could be wrong with them. In terms of the differential diagnosis, so for example, if someone is coming with chest pain and I'm a bit concerning about possibility of, let's say, PE. So I'm not going to say I'm concerning about having blood clot in your lung, but rather I would prefer to say I would like to make sure you don't have blood clot in your lungs. Because if I said I'm concerning that you have this serious diagnosis, that will leave my patient in very stressful situation. And they will be very anxious. And sometimes they might wait for hours and hours before we have the answer. So there is no need to keep them in this situation, but rather I would say, I want to make sure you don't have this and this.
Yes. So
So they know that the doctor just would like to make sure. So they will be fine and they will be sitting and until you have all the results you are looking for. Do you agree with this?
Yes. Yeah, that's right. And I think it will be just like while they're waiting for the blood investigation, they will be in severe psychological stress and mental stress. And it will be just like very horrible couple of hours waiting in the observation area. And when they're coming inside, you can see or can feel their anxiety. And while you're going to tell them about the results, so I think it is right things to tell them that we need to rule these things out. It is much more reassuring that rather than telling them that you're concerned that they got a clot in the lung. It is just like you already agreed and you already just like have positive diagnosis for them when you're going to tell them that I'm concerning about clots in the lung. So I think it is big different, isn't it? Yeah, in the way of pronunciation of this. It is the same actually, but the way we are saying it, it is important to make sure that we're not adding extra burden and mental stress to the patient.
Yeah. And what about safety netting at the end if you are planning to send the patient home? Is it important?
It is very important, safety netting, because sometimes the patient might think that if you are discharging them home, they don't have the right to come back again if their symptoms worsening. So by giving them the safety net, at least they will be reassured that they can come back at any time. And I'm just preferring to give them verbal and written instruction as well, because sometimes the verbal might be forgotten after a couple of hours. I'm going to augment that as well with written plan or written red flags. If any of these red flags happen, you need to come back immediately to the emergency department. Sometimes I'm saying to my patient, even though after 1 hour, if you felt yourself not right or things is getting worse, that's fine. Just come back. At that time, again, we're going to give you more care. We're going to keep you in the hospital at that time. So like this, they will be reassured and they are happy about the plan. And we are at some point in the busy emergency department, we're forgetting to give them the safety netting, which is, I think, it is the most important thing in the management plan, particularly for the discharged patient. And like this, you will increase their awareness and that they got the right as well to come back to the hospital. Because as I mentioned before, they might think that, okay, my session is finished in the emergency department. There is no any things mandating me to come back to the hospital. So it is important, yes.
Yeah. I would like just to give an example of about this as well. So, for example, let's say I saw a young patient coming with abdominal pain, and clinically, I'm not really concerning about acute appendicitis. It's highly unlikely to me after my assessment. So instead of doing a CT scan just to make sure and exposing the patient to the high dose of radiation, to the IV contrast, I will spend a few minutes more with them and I will talk to them. I will explain that their tummy pain, it doesn't sound like something serious. It doesn't sound like something needs operation. However, and I'm happy for them to go home. However, we know sometimes, for example, appendicitis might be quite tricky initially.
Yes.
So I will give them a clear advice. If this pain is, like, for example, moving from here down there, or if your symptoms are worsening, or if you start to feel more pain or vomiting or whatever, then you need to come back and have reassessment. So in this situation, likely they will go home, and if it turned to be acute appendicitis, they will come back after a few hours or the next day morning, and they will say, we met a doctor called Mohammed, and he asked us to come back if our symptoms worsen. So they will be fine most of the time. It's not good to miss. However, clinically, if we are not concerning, we need to, I would never say everything is all right, go home. But I will give good safety netting advice, as you said. And if your symptoms worsen or any new symptoms, you need to come back to us. Yeah. And that, I think that will prevent a lot of problems, patient safety. The patient will be aware, the family will be aware, for example, if they are accompanying him. And also in terms of complaints, I think that prevents a lot of unnecessary complaints against us as emergency medicine practitioners.
Yes, and I would like to add one point here. So if we didn't provide the patient with safety netting and to come back to the A&E if their symptoms worsening, so if they went home without safety netting and their symptoms got worse, it is less likely that they're going to come to the same hospital, because they're going to think that we missed their diagnosis. So as a result, they're going to say that, no, that hospital is not right. I went there yesterday and they didn't manage me right and they sent me home and now my symptoms are getting worse. So I'm going to visit another hospital. So this is also a big issue. But if you give the safety net, they will come happily back to the same A&E. Even they might come to the same doctor if that doctor in the shift.
Yeah. And let me highlight the opposite to the concerning patients. Sometimes we might have a patient who is not concerning. So, for example, you are concerning that he might have serious problem, but the patient himself is not concerning. In this situation, I would talk to the patient. I will try to explore why they would like, for example, to go. Sometimes it could be something simple. Sometimes they might, because people might be in the hospital, in the emergency department, sometimes for about 24 hours without having something to eat, without having something to drink. Sometimes they might have a family member waiting for them. They might be tired. They might need to go and pick their children from school. So I think we need to explore why they want to leave, despite that we are, concerning about, or we would like to make sure they don't have serious issues. Because sometimes probably offering a cup of tea or coffee or a sandwich, maybe that all needed for our patients to stay, because they have been here for a long, long time. And usually I would say it's just because of your, for example, your age, because of your other medical problems you are having. Probably people might have like hypertension, diabetes, previous heart attacks, kidney problems, COPD. We need to make sure that you don't have something serious like heart attack. And that's why we want you to stay, because if they have full mental capacity and there is no self-harm and there is no mental health issues, then we can't keep patients by force.
Yeah.
Instead, we need to talk to them and convince them to stay. Yeah. And can you tell me about the angry patient, Hassan? I know you have a special interest in this group of patients, so can you tell me?
Yeah, so I think this is a common presentation to emergency department, and we are facing angry patients more frequent than other specialties. So there are many reasons for the patient to be angry in the emergency department, and surprisingly, most of the reasons of their anger, they are just like manageable causes. For example, waited for a long time without being seen, or the patient being seen but there was no follow-up, or no one is telling them about the result of their blood or what they're waiting for and what's the plan for them, or their loved one is in agony or in pain and need to be seen. And so there are just like very minor causes for their anger and needs to be managed appropriately in the emergency department. And I think we need to have a good communication skills to manage an angry patient. So me, myself, I'm inviting the angry person in the emergency department to the private room. I think this is one of the initially important steps for managing angry patient. Because if I'm going to address his anger or his concern in front of other people, might not be a good idea. The reason for that, because he's going to be affected by the people surrounding, and he might his tone might be escalated, and he's going to be affected by the people surrounding him. And he need to show that he's angry, so he's going to escalate. And so I think like this, we're going to lose the rapport. So I'm just going to tell them that I'm going to introduce myself, that I'm one of the doctor. I'm here to address your concern. Please, can you come with me? So I'm just going to invite them to the private room. And then the most important aspect of managing angry patient in the ED is listening. Those people are angry because they didn't find anyone to listen to them. So by listening to them, you're giving them the chance to express their feeling, to rebreathe their anger, to tell you the concern, why they are angry. So just do not interrupt them, give them time. After that, try to address their concern. And as I mentioned, most of their concern are manageable things and easily be addressed. And the other important thing with the angry patient is to not take their anger personally. They are not angry because of you. They're angry because of something happened in the emergency department. Most of us, or the majority of us, they are just taking these things personally, that he's shouting on me. Why are you shouting on me? So this, I'm going to escalate back, and he's going to escalate back as well. So the tone will be high, and eventually I'm going to lose the rapport, and the situation will be out of control. and like this, that's done. It is difficult for you now to go back and cut yourself. No. So just like give them time, invite them to the private side, give them time to talk, do the active listening, address their concern, apologize for them, and then try to fix their issue.
Apologize for what?
Apologize for their concern because, for example, they waited for a long time without being seen. I'm going to give the apology. So I'm really sorry that you waited for a long time without being seen. So we are here in the ED. We have a lot of patients, and our priority is to see all of you. And we are doing our best to see all the attendants in the emergency department. And so shortly we're going to come to see you. Meanwhile, I can address, if you got any pain, I can provide you pain medication. If you want to have some drinks while you're waiting, so we can provide that to you. And I want to reassure you that we're going to see you as soon as possible. This is after giving them the chance to tell me what's their concern, why they're angry.
Yeah. I mean, yes. Apology. I think apology is really important. And it's not necessary that we are apologizing for mistakes. So, for example, I could say, I'm really sorry that you feel you haven't been managed well. So still, I'm not admitting that we did something wrong, but I'm trying to de-escalate. So I'm really sorry to hear that you feel you haven't been treated well, or, for example, you have been waiting for a long time. And then I will explain that it's quite busy, but I do apologize to you on behalf of the department. And of course, there is zero tolerance for bad behavior. So we don't accept assault. We don't accept being insulted or any of our colleagues. But it needs a balance. So yes, I think good communication 90% of the time will prevent that escalation. And sometimes at the end of this few minutes conversation, the patient will be quite comfortable and they are happy to go back to the waiting area and wait again.
And they can wait more.
Yeah.
So they are angry because of waiting a long time, but after good communication, they are willing to wait for more than a couple of hours, 3 hours. So they will be happy because their address is concerned. And you mentioned an important point. So yes, there is zero tolerance for any abnormal behavior or harassment or abusive things to either to us as a doctor or any one of the medical staff. So that's will be not accepted from the patient side.
Yeah, and to be honest, waiting hours and hours to be seen, that's really distressing. I remember a long time ago, I was a patient and I was awaiting for about 8 hours to be seen. Believe me, I remember those. Probably they were the most stressful 8 hours in my life. It's just awaiting to be seen.
Yeah. So waiting in the emergency department is not a pleasant thing, but sometimes we're just like facing that we have large number of patients to be seen, and we are just like prioritizing ourselves to see all the patients. And I think we need to address the role of the nursing team. I think they're doing excellent job because while we are seeing patients and the patients waiting in the waiting room, you can see the nursing team as just like doing a round through the patient sittings in the waiting area. They are checking their vital signs. They are reassessing them to see if there is any changing in their symptoms. They are just offering them any just like snacks or cup of tea or coffee or water, making sure that they are good. So I think those things might just like make the waiting stressful time less, with the patient just like appreciating that someone is coming, checking on them, checking their vitals, making sure that they are all right. If they need anything, so it can be provided to them. I think this is also might help them as well.
Yeah. And there is another category or another situation when we misdiagnose or we mismanage when there is an incident. So in these situations, we need to be honest. We need to be transparent. We need, first of all, to make sure that our patient is safe and make sure that there is a good management plan for the patient for what has been missed. And then we need to sit with the patient and or with their families and explain what happened. And also we need to apologize. And I think in this situation, we will apologize for what we've missed. It's not like I apologize that you feel you haven't been managed well, but we will apologize for what we missed. I think that's the most important, again, to prevent escalation. The patient have the right to, to complain, and actually I think it's our legal duty to guide them and to offer them if they would like to, to make formal complaint and provide them with the pulse information and how to issue the complaint. But we need to be honest with them. We need to explain everything happened and what we are going to do next. If you have anything to add on this, Hassan.
Yeah, so I think here the main point, to be honest and to be realistic, and you need to apologize for that. And as you mentioned, the apology should be clearly, because there's error here happened, and we need to admit the error happened, and we need to apologize for that. And the things which I'm going to add in here, I will just raise the matter of improvement, that we're going to take this incident just like for the purpose of improvement in the emergency department and to the type of care provided to the patients coming to the ED, for this error not to happen again in the future. So I'm just going to state that, or making this statement clear to the patient, because the patient might start to think that if this happened with me, I'm afraid that this might happen again to other patients. So by this statement, I would just like highlight a very important point, that this incident, we're just taking them into consideration to make sure that this is not going to happen in the future. And then, as you stated, I'm just going to speak to them about the treatment plan for the missed things and what we're going to do for them. And the apology here, I'm just thinking, while we are talking to the patient, we can give the apology more than one time. I think this will also be just like giving the patient a state of calmness, and we're just going to absorb their anger by a couple of times saying that we are really sorry for that, for this incident. And so this is my just like also building the rapport between you and the patient. Some people thinking that if we apologize, and it will be just like a bad issue for us, or a bad issue for our care plan to the patients. No, so this is, things happen here. So this is fact. And so we need to admit that, and we need to learn from our mistake, because mistakes keep happening.
Yeah.
And we need just like to take the learning points from all the mistakes or the errors happening in the ED for them not to happen again in the future.
Yeah. All right. So let's go a bit further on. What about the confused patient?
Right. So this is also a bit of frequent things happening in the ED, assessing the confused patient. So a patient might come to the ED and being confused for a variety of reasons. So they might be particularly elderly patient. They might be septic, or they might have some sort of infection, or they had unwitnessed fall, after which their level of consciousness being deteriorated. So I think for those patients, the important thing to manage them in the A, B, C, D, E manner. And then particularly when we're coming to the D part, assessing their cognition and their level of awareness. This is quite important, because sometimes the patient might answer a couple of your questions right, but if you went further for assessing their cognition, you might feel that their level of awareness is not right. And this will affect your management plan. because based on that, your management plan will be different from the normal patient with full cognitive function, isn't it?
Yeah.
So I think in the D part, there are several scores which we are using them to assess the level of cognition. But before that, I'm just going to ask the patient, the relative of the patient, if they are there, or if the patient coming from the nursing home, I'm just going to speak to them. If I've noticed that during the conversation, this patient is not right and there is some sort of confusion, patient is confused or his cognition is impaired, I'm going to ask them to see the normal status or the normal level of his awareness or her awareness. And then based on that, I'm going to proceed further to assess the full cognition of the patient using any one of the scores. And then based on that, we're going to formulate a good management plan. And I think the most important step in the management plan, just to make sure that this patient is not septic, and to check the random blood glucose. I think this is bedside investigation, which is very rapidly accessible and can be done easily and very fast, and will give us a lot of information, because we found a lot of people, for example, they're confused, and the reason for their confusion is just like because they are hypoglycemic.
Yeah. And I think sometimes confusion could be quite subtle, and even we might not notice it. And I remember seeing a lot of patients before, and actually they give the wrong information. They are not lying, they are just confused, and you might not notice that. So for example, like when asking a patient, who do you live with? He's going to say, I live with my wife. But actually the patient, probably his wife, she died long time ago, and he lives in a care home. And then someone coming later on, or the notes accompanying the patient will say that he lives in a care home, while he said to you that I live in my house with my wife. So what I used to do, if there is any concern that the patient might be confused, from the beginning, I would tell the patient, listen, I'm going to ask you few questions, which they might sound silly questions. But actually, I would like to make sure that you are not confused. Is that okay? And then I proceed. And personally, I use the ANT4. So it's just 4 questions. Can you tell me your date of birth? Tell me how old are you? Which year is this? And tell me about your address, for example. So I think they are quite simple. And then they will tell you if the patient is confused, because you're not going to miss important things about the patient. If the patient is overtly confused, then I think we need, yes, agree with you, we need to collect collateral history. So that could be from a relative, from support worker. We might need to go back and give a phone call to his next of kin or to the care home to know the events and the baseline and the background. So this is important consideration.
Yeah, and it did happen with me a long time ago. I was seeing one of the patients. Inside the room, there was one of the relative of the patient, and the patient is answering the question very appropriately. But after I finish the history taking from the patient, that relative came outside the room, and he is telling me that all the information he got, it's not right information. Our address is this address. You can check that in the system. And so I found that the patient is quite confused. But for me, initially, when I was taking history from him or having a conversation with him, they're just like answering the question appropriately, but they answer them wrongly. So the patient is quite very confused. And as we went through the management of that patient, we found that there was significant cause for their confusion. So I think assessing the cognition for particularly elderly patient, I would just make it as a habit in the ED. When you are seeing any elderly patient, just please go and assess the cognitive function of the patient, which is very important, because this is might just like give you completely different way of management plan. Yeah.
And talking about elderly patients, which is happening frequently, and I was doing that myself before, that when you go to see the patient, and usually there will be a few relatives with him, probably his son, his daughter, probably his wife as well. So sometimes, because the relatives will be quite, concerning about their, their loved one, about the patient, they will try to immediately, take the lead and tell you the whole information. I think that's not the right way to start with, because that will give the patient the feeling that he's been ignored. If I come to the room and then after introducing myself, I talk to the relatives, the patient is like probably an elderly, frail patient, and probably they feel that they are quite weak, and if you immediately ignore them and then you start to talk to the relatives and not putting attention to the patient himself, I think that will cause some sort of psychological trauma.
Yes. Yeah.
So I'm trying to make it like a habit. I would talk to my patient. So even if he's quite unwell, even if he's confused, I will keep talking to him. I will keep eye contact with him,
Yes.
even if I'm expecting the answers from someone else in the room, rather than putting my attention to to his accompanying people.
Yes.
Do you agree with that?
Yes, and sometimes the patient might start to give you the story, and they might find it difficult to have formulation of the word or to speak, or they're speaking very slowly, and one of the relatives is just like jumping to take the lead of the conversation. In this entity, I will just give the patient time to speak for themselves if they are able to do so. I will just give them time. I will not hurry myself just like to either involve the parent, the relative inside the room. I will just sit beside him, give them time. Even they're talking slowly, because they are weak, because they are sick, they need time. So just give them that time to express their feeling. Once you shift that attention to the relatives, I think the patient is not going to feel right. That totally agree that he will feel that he's been ignored, which is not the case here, because he's the patient and our care is just like directed to him, or to her. So I think we need to give them a time to explain more and more. And this, I think, will bring us to another very important point in terms of the language barrier between us and the patient. So the patient is not speaking the language, or they have barrier issue in the language. So sometimes we are using their relative to be like an interpreter. And here we need to focus to the patient while we are getting the information from the interpreter. And when I'm asking the question, I'm not asking to the interpreter. Rather, I'm going to ask the patient. Although I know the patient doesn't know the language, but my focus, my attention, my speech will be directed to the patient themselves, and then the interpreter is going to do that. Either the relative or the phone interpreter, the formal interpreter. So I'm tending to use the formal interpreter rather than the relative. I think this is quite important here, because it's not a matter of that I'm not trusting the family, but it will be more formal. And I think the patient sometimes might need to tell something which is important and special and private for them. And it will be difficult to hand this information to their relative to give it to me as a doctor. So I think with interpreter, formal one, it might be much more easier for them, and I can get more information through the formal interpreter. But even though, while I'm holding the phone, inside the conversation, my all focus, my all attention, my body language is all directed to the patient. So like this, the patient will get the proper care that they needed.
Yeah, exactly. And yes, I agree. And actually, this is sometimes could be medical legal, because we shouldn't use the patient relatives as interpreters, because, as you said, sometimes they might have hidden agenda as well, or they might just want to express what they think the problem with the patient rather than telling you what the patient is saying. and also for the patient privacy and for confidentiality. So yes, I think it's better to use a formal interpreter rather than using the relatives, because if anything happened wrong at the end of the day, I think because that will be a source of blame. Like, why did you use the relative as interpreter? But yes, we need to focus on the patient. That's the message.
Yeah.
Let's touch the issue of sexual history. So, what's important when you have a patient and you think that you need to collect some sexual health history from them because their problem today might be related to their sexual health. So, what measures you take when you are doing that?
Yeah, so this is a very sensitive issue, and most of the patients, they are not feeling comfortable to share all these private information with you as a doctor or as a healthcare provider. So once I've noticed that, my direction of the conversation will go toward asking the patient about a couple of questions about sexual activity. Before doing anything, I will make sure that I had my introduction done. What sort of introduction? I'm just going to state to the patient clearly. So I'm going to ask you several questions. Those questions might seem a bit personal, and I want you to feel comfortable sharing all the information with me as much as you can. I will reassure you that all this information will be dealt with confidentiality and dignity, and no one will have an access to the information unless with your permission. So apology again. So this question, it is just like to formulate for you a good management plan. Are you happy for me to proceed? Taking consent as well for that. So I think this introduction is a bit important, because like this, the patient will be able to share all the sensitive information with you. Without doing this introduction, I think the patient might start to ask themselves, why are you asking me this question? What is the relevance of those questions to my presentation? Because they are not in the medical field. So they might think that their related problem coming today to the emergency department is not due to sexual activity. So they don't have the link between all these issues. So you need to make it clearly for the patient that all this information will be asked about. It is to formulate for you a good management plan. It is to address your main presenting symptoms to the hospital today. And so like this, I think the patient will be more reassured. Even though after this initial introduction, as you are going through your questions of sexual activity, it is important to keep apologize while you're asking questions as you're going through. Keep apologies. Because I think this is quite important and it's quite sensitive. And one thing I want to add in here as well, if there is someone in the room, I'm going to ask a permission. Are they happy for that person to be inside the room? For example, one of their relatives or their friends, because sometimes they might feel uncomfortable with the presence of someone stranger inside, and they don't want this stranger to have access to those information. So I will take their consent. If they are happy for that person to stay in, that's all right. If no, I will just ask that person politely to go out, because this is sensitive information. Mm-hmm. And I think all the incidents and the complaint are coming from here because we didn't make a good introduction or giving them just like a warning that you're going to ask these questions and why you are asking these questions. So you need to explain this matter clearly. And you need to make sure that the patient understands all the things mentioned before starting asking the questions.
Yeah. And I think the opposite is true as well. If the patient is not accompanied by anyone and they are alone during the interview, I think it's appropriate to ask them, do you want anyone to attend while we are talking? And if they would like someone, probably might say like my partner or my friend outside, I would like them to come, then I think we will be happy as well. as long as this is their wish. Is that right?
Definitely right. Yes. Yeah.
Yeah, yeah. And even for examination, for example, like if you would like to do like vaginal examination, rectal examination, breast examination, so these are quite sensitive examinations. Then again, I would like just to confirm this point. We need to have very good communication skill with the patient. We need to explain to them in full what is going to happen. They should be a chaperone all the time, and they should be again assured that if you are going to explain what you are going to do, and if they want you to stop doing the examination at any point, then to feel free to ask. If they want anyone to attend that examination, again, we'll be happy for that. I think communication is a cornerstone in these situations.
Yeah, actually for everything, yeah, particularly for these intimate examination things. And I think here we need to, even though when we're exposing the patient after offering them a chaperone, and when we're coming to make an exposure, for example, examining the breast or vaginal examination, so we need to cover the patient. We need to make sure that the patient is in the private room, the curtains are closed, and me myself, I'm just going to bring a cover to the patient, and I'm just going to cover as much as needed, just to maintain the dignity for the patient. And so this is, I think, it is quite important. And as I'm doing the examination, I'm going to warn the patient by every step which I'm going to do it, telling them I'm going to do this. So like this will be, they know what's coming next. So just like step by step, go through that, and then just like explain to them what you're going to do step by step. Keep their dignity maintained, cover them, and just like expose the very small area for your examination. And then once you've done that, tell them that you finish your examination, and then me myself, I'm just going out to give them time to redress back, and yeah, I will ask them.
This is really important. I'm sorry for interruption, but
No.
I mean, after examining the patient, any type of examination, then I don't think it's appropriate to talk to them about what's next while they are lying on the bed exposed in front of you.
Yeah.
I mean, we should give them some time, to get dressed back. So usually I would say, I'm going to be awaiting outside. Take your time, and when you are ready,
Call me back.
Call me back so I can come and talk. Yes. I think it's inappropriate to keep talking to the patient when you finished your examination, but still they are exposed in front of you.
Yes, and you are standing, telling them the finding, and they are exposed. So I think it is inappropriate. Yeah.
Okay, let's move on. What about social history? Is it important to have some social history from our patients?
It is important. So social history, it is, because sometimes the management plan, it will be depend on the social history. So social history, including the job of the patient and their living circumstances, and for example, and as well including the smoking habits, drinking alcohol, using of illicit drugs, and so this is generally included in the social history, because sometimes the main problem, it might be due to one of the aspects in the social history. For example, patient came with back pain, and socially, when we ask them what is the nature of your work, he's working, for example, he's lifting just like bags in the airport, or he's working as a lifter. So now you know that the main problem is due to his social aspect. So I think it is quite important to address the social history, because it might give you the clue about the main presenting symptoms. Another example, that patient is having bad drinking habits, and he came with signs and symptoms related to the drinking habits. So like this, you can link things together, and you can know the cause of their main presentation. Yeah.
Yeah, and I think particularly for the elderly patients, we need to make sure about if they have carer, who does they live with, do they live with, do they live alone or with someone else or in a care home, who's doing the cooking for them, who's doing the shopping for them. I think that's really important because yes, the management plan largely might depend on that. Do you know that there is large number of patients who are in the hospitals for a long time, even though they are medically fit for discharge, because they need a discharge plan, so they need some adjustments at home, because the care we are providing, it doesn't finish in the door of the emergency department, but it continues until the patient home. So yes,
Yeah.
I do agree with you.
Yeah.
And what about communication with our nursing colleagues? Do you think that's important? I mean, for example, you see your patients. Is it important to go and talk to your nursing colleague and update them about what you think that going on about your plan? Do you think that's important?
It is. It is very important, and so having communication with nursing team, I think it is a crucial aspect in the management plan, and the nursing team, we need to appreciate their role in the hospital. So they're just like doing a lot of things, and which should be appreciated, and they got a bit of heavy load for them as well, and they are doing too many things, and I think it is appropriate to engage them with the plan. So me myself, after seeing any patient, next step is I'm going to speak to the nurse taking care of that patient, telling her the plan and what we're going to do and what we are suspecting for this patient. So like this, they will be aware, and we are going to be in the same page, and we need to offer them help because they are doing a lot of things. If we felt that we can do something to help them, so I think that will be appropriate to just like lift the heavy burden from their shoulders, because at the end we're working as one team, and our target is just like to provide a good management plan for the patients. So if we can do something to help them, I think that will be totally appreciated, and they are appreciating this if the doctor is coming helping them with everything, even though if it is just like related to the nurse. I know that everyone having a plan of duty inside the hospital, but sometimes we need to help each other. And I think communication with nursing team, and not only the nurse taking care of that patient, but the charge nurse as well. So I'm just going to update the charge nurse with the plan. And from time to time, I'm approaching to the charge nurse, discussing the plan of my patients in the screen. So this one is waiting for that, and this patient, the plan is this, and this patient, the plan is that. So like this, he will be on board with you, and the plan of the care of the patient will go smooth, and I think the disposition even of the patient will be much more easier. Most of the physicians, they have these miscommunication issues with the nurses, and I think we need to keep that in our mind, that we need to have a good communication with them, helping them, sharing the management plan with them, telling them about the plan, what we're going to do for the patient next. And the other communication part is just like to support them, because sometimes they are in extreme distress, particularly when we are facing with the busy emergency department, and there is a lot of stress going on to the patients, to the doctors, to the nursing team. So as a leader, or just like as a physician, so it's not particular to be a leader, but as a physician working there, it is your role to reassure them and to appreciate the things that they are doing in the ED. So I think this will give some sort of psychological support for them, and they're going to appreciate that. It is just like simple words and being nice and being supportive. So this will affect their management things, for the patients.
Yeah. And yes, I do agree. So all emergency medicine doctors, by default, they are leaders. Yeah?
Yes, yeah.
But yes, it's important to have good communication with our nursing colleagues. And I understand that they are under a lot of stress. It's just the same as what about the doctors as well. And sometimes you might find one nurse is responsible about 5, 6, or 7 patients. Imagine that you should, check their observations regularly, give the whole medications, and do other things as well. So that's quite, I don't say difficult, but we need to help. We need to help each other. And you mentioned something important. You said it's important to have good communication with the nursing staff to be on the same page. And yes, sometimes you might see a patient and he needs urgent treatment. But if the nursing team, they are not aware about the urgency of the situation or about what you are thinking about they might be having, then you might request something and then it might happen after a couple of hours when it needs to be done within 5 minutes or less. So I think it's a good habit that every single time we go back, we talk to our nurses and also update our nurse in charge. Those people, they are quite helpful, they are quite experienced.
Yes.
And personally, I have learned a lot from them during the years. So at the end of the day, because our aim is to have excellent patient-centered care. Yeah.
Yes.
And a small point to highlight, sometimes you might be required to administer medication yourself to the patient. For example, like emergency treatment. For example, you want to give adrenaline for someone who's having anaphylaxis in front of you. So that's just an example. So it's really important before administering any medicine to any patient is to make sure about this is the right medicine and the expiry date. And it's really important to have someone else to check these details with you. Okay? Other example is like when we do like fascia iliac block. So we grab the bupivacaine, but we need to have someone to have second check with us, because sometimes we might make mistakes in the busy department. So it's important to have it like a habit. Any medicine you are going to administer to someone, even if it's just IV fluid, then check it with someone else. That someone else could be a nurse, could be another doctor. Okay? So at the end of the day, because this is to ensure patient safety and to prevent errors as well.
Yes, that's correct. And I think the nursing team, they're doing a very great job about that. When they're giving the medication, they're just like double checking with you. And I think, yes, if we make it as a habit, that will decrease the possibility of error happening in the ED. Yeah.
We are, as doctors, we are not good as the nurses in this thing.
Definitely, yeah.
So we need to work on that. Fine. What about breaking bad news? It's just if you can touch it. I know we are not going to talk in details about breaking bad news. That needs entire episode.
Yeah.
Which hopefully we are going to do in the near future.
Yeah.
But if you can tell me just a few important things when breaking bad news.
Yeah, when happened, for example, a patient died in the ED, and you confirm the death. So the next step, it is just like crucial, because sometimes if you lead the code of that dead patient, you was under stress running the code, and now the code is finished. Now another stress is starting for you to break the bad news for the relatives. So I think it is better just like to have a couple of minutes with yourself after finishing the code, just like to shift and switch your mind from that stressful which happened during the resuscitation to the period that you're going to speak to the relatives. So I think this is which is very important, because like this, you're going to arrange your thoughts and you need to charge yourself back and to prepare your emotions and your mental aspect before speaking to the relative. So just like take a couple of minutes, take a deep breath, and prepare yourself mentally, and then invite the relative. I think usually the relative will be in the relative's room. They're waiting for your news. Once you are ready, you need to be accompanied by someone. You need at least to have the child nurse with you. So speak to the child nurse that I'm going to break the bad news for the relative. So let's go together for them.
Okay, all right. So we'll leave the rest of conversation about breaking bad news to one of the new upcoming episodes. Is that okay?
Yeah, I think because there are many aspects need to be covered here. Yeah.
Yeah. The last point for today is about children. So what's important when you see a child? I mean, from communication point of view, what's important to you to consider?
To build a rapport between you and between the child, because usually it is a bit tricky, and people hate to see a pediatrics because they think that it is quite difficult to have a communication with the child. So before everything, I'm just going to introduce myself to the child and to his mom if he's accompanied by one of his parents, and then I'll try to build a rapport by any means, just like to make sure that the child is welcoming for me. Because for him or for that child, I'm a stranger. So I need to make a bit of communication with him before starting. And if the child is in the age appropriate for conversation, so my conversation will be directed to the child. I'm going to ask them questions, just like assuming that he's an adult. So I think this also will build a good rapport between you and between the child. And sometimes if I feel that the child is a bit stressful, I'm just going to sit down either just like on the chair or just like down to the same level of the child. And I'll ask the mom or the accompanied parents just like to hold their child in their lap while I'm taking the conversation with the child. I think it is quite important just like to have some sort of engagement with the child by just like playing with them, just like telling them just like good things, and that they're looking good. I'm here to take care of you. You are very happy. So like this, some sort of engagement. So you need to have that before starting the conversation.
Yeah. And I think it is important to confirm with the people who are accompanying the child. It's important to ask about their names and about their relationship to the child. Definitely, so yes, it's not a good idea to assume this is the dad or this is the mom, but rather to ask, and can I confirm your relationship to the child? Because sometimes it could be just like his nanny, like family friend, teacher, and also to confirm if someone saying like he's the dad or mom, like do they have parental responsibility as well? And I think the most important, like when seeing any child in the emergency department, is to think about non-accidental injury.
Yes. And I think even before discharging the patient, you need to check the safety netting for the child. Is the patient safe or the child safe to go home? And there is no any elements in your assessment and your history and your examination for the child mandating you to think about non-accidental injury. We need to keep that in our mind. I think after seeing any child in the A&E, at the end, we need just like to make sure that we are not missing any sort of non-accidental injury. And I think this is also an important topic which we can address them in the future in depth, and to raise the awareness of other ED team about the non-accidental injuries. Yeah.
All right. Thank you so much. Thank you everyone for listening, and we are happy to answer your questions. If you have any question or comment, please feel free. And hopefully we are going to talk to you soon in another episode of Emergency Medicine Academy podcast.
Thank you very much. And if you also got any suggestions for any specific topics that you want us to go for it, I think, you can post that in the comments, and we will be more than happy to do that. Thank you very much.